Hey, today talking about acute kidney injury, we have the king of the kidneys, the knight of the nephrons, the conqueror of the collecting ducts, our very own attending of the year, Dr. Calabrese.
So I think I'm sufficiently socially distanced from all of you that I'll take my mask off. So acute renal failure, that's what we called it for years. But then those that really know came along and decided we shouldn't call it acute kidney renal failure because nobody knows what renal means outside of physicians and healthcare workers. So we should call it kidney. And failure, it's kind of a bad connotation. So it's now injury. So acute kidney injury is the proper terminology. But a lot of people still say acute renal failure. So this is the original definition. It's the definition I still use. I'm not quite so anal that I use the rifle definition or the KDIGO definition that we'll look at in just a minute. So basically, as we all know, it's abrupt loss of renal function manifested by a decrease in urine volume, a rising BUN and creatinine. Oliguria is less than 500 cc's a day, and anuria is defined as less than 50 cc's a day. Now, KDIGO, which, believe it or not, stands for Kidney Disease Improving Global Outcomes. Those are a group of nephrologists worldwide that come together and make definitions. So if you're kind of anal, you'll go by this. An increase in serum creatinine by 0.3 milligrams within 48 hours. An increase of serum creatinine or an increase in serum creatinine of 1.5 times the baseline over 7 days, or decrease in urine volume of 0.5 cc's per kilogram per hour for over 6 hours. So honest to God, if you ask me that after this lecture, I won't remember what that is. So you don't have to memorize it. You kind of know what acute kidney injury is based upon the rapidly rising creatinine and decreased urine volume. Okay, so to be very basic, 3 areas of renal failure. Post-renal failure, which we'll spend just a few minutes on, pre-renal failure, and renal parenchymal failure, which the majority of the talk is on. Post-renal failure, of course, is obstruction, blockage, back pressure on the kidneys, so they're not filtering like they should. The number one reason that occurs is prostatic hypertrophy. And don't forget about it because it happens fairly often. We had a case years ago, patient in Enid. Creatinine, I think, was 8 or 9. They flew him in from Enid to get dialyzed, examine him, huge bladder. All you had to do was just palpate his, have him put in a catheter, and his creatinine came down. So always think of that when you see a patient with acute kidney injury that doesn't have any other obvious mechanisms. Neurogenic bladder, and these are in order of how often they occur. So big prostate, number 1, neurogenic bladder, and drugs. Just something as innocent as antihistamines can cause neurogenic bladder, but especially opioids, tranquilizers, and then especially in diabetics who already have kind of a neurogenic bladder already because of their diabetic neuropathy, and then patients with neurological problems, previous strokes, and so forth. Of course, bladder tumors, uterine tumors, calculi or clots, and that has to be in both ureters if you have a calculus, or else you're not going to have acute kidney injury. And I haven't seen this in years. I used to see it a lot more often. I've been around a while, so 25, 30 years ago, where they use the OBGYN, do a hysterectomy and inadvertently tie off both ureters. Retroperitoneal tumors and retroperitoneal fibrosis. But the ones to remember: big prostate, neurogenic bladder. And by the way, what do you think the number 1 cause of obstructive acute kidney injury is in females? it's uterine tumors. So in post-renal failure, the individual has a waxing and waning urine output. One day you might see 1,500 cc's, the next day you see 20 cc's. Hematuria is often present. And remember those RBCs, and we're going to talk about the importance of seeing RBCs in just a minute in patients with acute kidney injury. But those RBCs are normal appearing RBCs, whereas RBCs that come from patients who have glomerulonephritis are abnormal looking RBCs, call them acanthocytes, and they kind of look like a diamond ring. They come up and then it's a ring, and then there's a little protrusion at the top. I didn't put a picture of it, I should have. And because patients with obstructive uropathy often have stones or clots, and there's lots of back pressure from prostatic hypertrophy, they often have flank pain, like I said, anuria. You don't usually see anuria in acute tubular necrosis, but you do see it in obstructive uropathy. And just palpate the abdomen. We have our bladder scans now that anybody can do on any floor. And an ultrasound, of course, usually shows hydronephrosis. All right, so much for post-renal acute kidney injury. Pre-renal azotemia, we probably see more often than we recognize. I'll categorize this into 4 areas. First, those with volume depletion. We all understand volume depletion and pre-renal azotemia. And those are the things up there that can cause burns, sweating, hemorrhage. And the one that I'm probably most guilty of is excessive diuresis, because generally we're dealing with patients with cretins of 3, 4, on an outpatient basis, have their Lasix up to 160 twice a day sometimes, add a little metolazone, and then they go out and in the heat, or they get diarrhea, and all of a sudden they're in the hospital with a creatinine of 7 or 8. Then those situations in which the patient has acute kidney injury and yet has an increase in intravascular volume. And these we usually see in the intensive care unit. Septic shock is number 1. And as we'll see, septic shock is the number 1 cause of death in patients who have acute kidney injury. Cardiogenic shock. So just realize this, these folks have too much intravascular volume. Their intravascular volume is increased, and yet they have decreased perfusion. Cirrhosis. And those with excessive volume outside of the intravascular space result in acute kidney injury and nephrotic syndrome, acute pancreatitis, and again, cirrhosis. And if you're unfortunate enough to have renal artery stenosis in both renal arteries, that will, of course, cause acute kidney injury. Generally, what happens there is a patient has had renal artery stenosis for some time in one artery. Usually, you're talking about an individual over the age of 65, usually Caucasian, and then the other renal artery is slowly closing down, and all of a sudden, you see a rise in the creatinine. Now, here's the biggest list, and this is what we're going to spend most of our time on. Those patients who have acute kidney injury due to intrinsic renal disease, renal parenchymal disease. And right at the top is ATN, acute tubular necrosis. Now, acute tubular necrosis is indeed necrosis of the tubules. So you would think that nobody could recover from something like that if you've necrosed your tubules. But in fact, if you do a renal biopsy on a patient who has ATN, you may not see any necrosis at all. The necrosis in acute tubular necrosis is very patchy, little bits, but it causes a shock to the tubule so that there are problems that occur that we're going to see in a minute that result in oliguria. And think about that. What's the primary function of a renal tubule? It's to reabsorb. And yet, when one has acute tubular necrosis, a tubular problem, that individual is oliguric most of the time. Matter of fact, 75% of the time. So, patients can have acute tubular necrosis due to decreased perfusion for whatever reason. They might have an increased intravascular volume. They still have decreased perfusion. Or they can have acute tubular necrosis because of nephrotoxins. Those patients with ATN due to nephrotoxins are generally non-oliguric. That's non-oliguric ATN, where the hypoperfusion ATNs are almost always oliguric. I'm not going to go through this big long list. Just suffice it to say, the top three after ATN are only 5% each. Patients with bilateral ring artery stenosis, acute interstitial nephritis, and rapidly progressive glomerulonephritis due to things like lupus and ANCA-positive disease. Cholesterol embolization syndrome, I used to see it a lot more often than we do now. I think they're doing a better job, but basically, that's almost always individuals who've had a catheter go up their aorta for whatever the reason. Kind of scrapes off little bits of the cholesterol, but it's not hunks of cholesterol. And so cholesterol emboli syndrome is like as if you would see water in the sunlight. Just a little spray of a whole bunch of little cholesterol droplets that get into the microvasculature of the kidney. So sometimes it's difficult, and the individual who has had a heart cath determine whether their acute kidney injury is secondary to the contrast that was used or due to cholesterol emboli syndrome, or perhaps both. So let's go back to volume depletion or decreased intravascular volume as a cause of pre-renal azotemia and ultimately of ATN. So let's say you're out on a day in July playing tennis at 3 o'clock in the afternoon and you get a little dehydrated. Well, everybody knows if you get a little dehydrated, you don't pee very much. Call that physiologic oliguria. But if for whatever reason you fell and hit your knee and you went to the emergency room and they did the usual battery of tests, even though you just scraped your knee, they found that your BUN was 80 and your creatinine maybe was 1.6. So that's pre-renal azotemia, the findings of pre-renal azotemia. A little bit of volume, boom, everything's better. Incipient ATN is something we just had to make up because there's a group of individuals who, as that volume depletion continues, let's say you won the game and the guy that you beat was driving, he got mad and he left you out there in the heat. You had to walk home. And by the time you got home, you were really volume depleted and you went to the emergency room. And now your creatinine is up to 3.2 and your BUN is 80. And they give you some fluid because you really look really dehydrated. You have orthostatic hypotension. Give you some fluid and you don't pee. You get 3 liters of saline and you still don't pee. But then somebody comes along and gives you 80 of Lasix and you do pee. So that's why we had to make that up. That's that group of individuals, and it's not very many, that don't respond to volume, even though they're volume depleted, but do respond to a loop diuretic. An established ATN, and that's what we're usually looking at, intensive care unit, especially with patients with sepsis. You give them volume, you give them diuretics, and they don't get better. And the very last down here is a really unusual thing, cortical necrosis. This only occurs in otherwise healthy individuals that suddenly have volume loss. So, abruptio placenta. So that's always, a young individual loses lots of volume. They lose so much volume that an older person would die. But these people live, but their kidneys do not recover because the whole cortex of the kidney is gone. Or a young person gets in an auto accident and has internal hemorrhage would be another example. So, I mentioned earlier, and I wanted you to be thinking about it, why would it be oliguric if you have tubular injury when the tubule's responsibility is to reabsorb? Well, here's how it goes. First, you have hemodynamic insufficiency or a nephrotoxin that causes renal ischemia. And by the way, nephrotoxins cause direct tubular damage too. They cause ischemia and direct tubular damage. Because of that tubular damage, there's back diffusion. So now the tubule is no longer selective in what it reabsorbs. It's like a sieve. Things just kind of pour through it. And that gets into the interstitium of the kidney and not into the tubular lumen. And then on top of that, because the tubule's sick and areas of it are necrosed, some areas of tubules are necrosed, there's a lot of debris. There's cellular debris, there's tam horsefall protein, and that gets in the tubule and kind of clogs it up. So that decreases urine flow. And then just the fact that all that fluid is coming out of the tubule and into the interstitium, the kidney swells. And as a matter of fact, one of the things that you'll find if you look for it is that patients with ATN have big kidneys. And that swelling, that tissue turgor pressure, pushes on the tubule and further decreases urine flow. Last and most importantly, there is a mechanism located in the distal part of the distal tubule that's adjacent to the afferent arteriole, so the tubule can tell the afferent arteriole, we're sick down here, don't send anymore. Because if you keep sending it, we're all going to die. Because we'll piss ourselves to death, literally. The patient would become terribly hypovolemic in a matter of hours if the volume kept, if the glomerulus kept filtering at its usual rate. Then lastly, there's some thrombosis in the glomeruli that occurs. So all of those things result in oliguria, but the number one mechanism is this right here. Can you see my pointer? Is my pointer up there? No? So we have the macula densa and these specialized cells in the afferent arteriole. The macula densa is in the distal tubule. This is the distal tubule. Here's the specialized cells, macula densa. These specialized cells in the afferent arteriole, juxtaglomerular apparatus. And these cells that come in these cells, you better not put any more blood into this glomerulus because we can't handle any more filtration. So the afferent arteriole squeezes down through the renin-angiotensin-aldosterone system. And that is the major mechanism. Now just think of it. There are 2 million nephrons, 2 million nephrons, 2 million glomeruli, and in every one of them we have this mechanism going on of afferent arterial constriction. So there was an article I read years and years ago. It said acute renal failure is acute renal success, because if this didn't happen, if this mechanism didn't happen, then the organism would be dead in a matter of hours. Okay, now we'll get a little more clinical. So your patient is oliguric, not making very much urine. What are the things you do to determine whether or not they have pre-renal azotemia, pre-renal azotemia versus ATN? Well, their fractional excretion of sodium. If it's less than 1%, that's generally pre-renal azotemia. Greater than 2%, that's generally ATN. But look, there's a big space in there, 1 to 2%, that you have to kind of figure out from your clinical acumen. Urinary sodium less than 20 is usually PRA, greater is usually ATN. This BU into creatinine ratio, usually pre-renal if it's greater than 15, or ATN if it's less than 10. If you have ATN, you have sick tubules. You cannot concentrate your urine, so the specific gravity and the urine osmolality are low, as opposed to patients who have normal tubules, just volume depletion. If you look at the urinary sediment, it may be normal or just a few fine granular casts versus what we call dirty brown or muddy brown casts. That's what they look like. So highly pigmented casts. Unfortunately, the lab will not report dirty brown or muddy brown casts. Sometimes they'll report highly pigmented casts. That's a real tip-off. About 75–80% of patients with ischemic or hypovolemic ATN. And when I say hypovolemic, I'm meaning anything with hypoperfusion. So hypoperfusion ATN, which would include sepsis and heart failure, by the way, will have these highly pigmented casts. So you can Google fractional excretion of sodium and put in the numbers, and you don't have to remember this formula. But just to conceptually understand it, remember that the fractional excretion of sodium is nothing but the ratio of the sodium clearance to the creatinine clearance. And the clearance of anything is urine concentration of that substance times the volume divided by the serum concentration of that substance with its creatinine or sodium. And you'll notice that the volumes nicely cancel out, and you end up, and to make this more mathematically pleasing, put this up here, and there's calculation. So you have a patient that has a creatinine that's 3.2, and the first thing you want to decide is this chronic or is it acute? Well, the history is going to tell you the most. Unfortunately, a lot of our patients haven't seen a doctor for some time, and they can't tell you, yeah, they told me 2 years ago I had a creatinine of 2.6. So now the history isn't helping us. Look at the urine. You see dirty brown casts, or if you have the lab tell you there's highly pigmented casts, then maybe it's ATN. The degree of hyperkalemia is actually helpful. Patients who have chronic kidney disease will tend not to have as high potassium because there's been adaptation to help excrete the potassium. Patients who suddenly have renal failure will have a much higher potassium. Individuals with acute kidney injury have more of an incidence of combined gap metabolic acidosis. That is, their metabolic acidosis is both due to bicarbonate loss and hydrogen addition or retention. So if you look at anion gap, that'll help you. Patients with chronic kidney disease generally have a lowish calcium 9.29, and a high phosphorus. Phosphorus not unusual to be 6, 7, 8 even. Whereas in acute renal failure, that process hasn't had time to take place. They more often have a lower phosphorus and a higher calcium. If you happen to measure a PTH, the PTH is not near as high in patients with acute renal failure. And anemia. Do you think anemia is worse or less in acute versus chronic? The anemia is less because you haven't had that much time for the effects of the lack of erythropoietin to have occurred. So the patients with AKI tend to have less intense anemia, and unless, of course, the mechanism of their AKI is hemorrhage, but their anemia is not as intense. And matter of fact, it's mostly just due to volume retention. Then we have a situation where the patient has chronic kidney disease. You know he has chronic kidney disease. You got it by his history. But all of a sudden, there's been deterioration, much faster than it should have been had they had chronic kidney disease. So we call that acute exacerbation of chronic kidney disease. And the first thing you need to look for are there any reversible problems here? Because if you just pass them off as chronic kidney disease, you're not going to do anything for the patient. So you look to see if there's anything that you can fix. And of course, volume depletion is the #1 thing. But remember, I just have to pound this, that patients with congestive heart failure will have a pre-renal azotemia and even can have acute kidney injury if they have cardiogenic shock. So that's a reversible problem in patients with underlying chronic kidney disease. And I would say we see this, well, of course I see it more than the average because I'm a nephrologist, but this occurs very frequently. Patients with bad hearts who don't take their diuretic or something comes along and all of a sudden they go into major congestive heart failure and their creatinines shoot up. And that's something that's easily reversible. Always look for nephrotoxins. And then this is the severe hypertension. Generally even a patient with 180 over 110, that's probably not going to make renal function worse. We're talking about patients with 240 over 140 in that range. And here's the drugs. This is the #1. These are not in order of frequency, but non-steroidals. Just a simple little question, but generally patients do not offer as a medication those medications they're getting over the counter. So that medication list is not always complete. Non-steroidals, big thing in patients with underlying chronic kidney disease causing acute exacerbation. And in our hospital, in the hospitals everywhere, vancomycin. Matter of fact, I was the expert witness in a case for the hospital. I'll tell you, wasn't this hospital. In a case of vancomycin overdose causing acute kidney injury. And if you've been here for a year or two, you've seen it. It happens all the time. And this is a small hospital. Any pharmacists in here? RMDs? I would have said it anyway. But if your patient has renal insufficiency of any kind, the pharmacist should not be dosing the vancomycin. I consider it an act of laziness on the part of at least our internal medicine people to allow the pharmacist to dose vancomycin in a patient with renal insufficiency. And in this case, that's exactly what happened. The case that I was an expert witness on, and I really couldn't give them any defense. Contrast is the other biggie. So non-steroidal anti-inflammatories, vancomycin, and contrast. We hardly use any aminoglycosides anymore. So rapidly progressive glomerulonephritis, RPGN, looks a lot like acute tubular necrosis. And it is a form of acute kidney injury, but if you got a lot of red blood cells in that urine, and if the lab happens to say RBC Cas, which they very infrequently do even when they're present, RBC Cas, you're probably dealing with the RPGN, where you're probably dealing with glomerulonephritis. And I think everybody understands. You see red blood cells in the urine in a patient with acute kidney injury, you need to give them that $1 million workup. Unless there's an obvious reason. I mean, they have cystitis, they have a stone. There's an obvious reason that there's red blood cells in the urine. And very often these patients go on to get a renal biopsy with RPGN. It's unusual that a patient would get a renal biopsy who we think has ATN unless we're not sure. So you have this oliguric patient, and you now want to decide whether they have it. This is the toughest distinction to make. I started with the easy ones. The toughest distinction to make is this pre-renal azotemia or is it ATN? History, yeah, I had diarrhea for a week, but you know, that could have gone on to ATN. Your physical exam, did they poor tissue turgor, orthostatic hypotension, the labs that we talked about, fractional excretion of sodium, are all helpful. You make your determination. If the patient has pre-renal azotemia and they're hypovolemic, easy solution, you give them normal saline. But just remember this, the labs are identical. That is, decrease urine sodium, decrease fractional excretion of sodium, increase urine osmolality. They are identical in patients with hypovolemic, pre-renal azotemia, or in a patient with congestive heart failure and pre-renal azotemia. Identical. BU and the creatinine ratio is high. So you can't just take that call and say, oh yeah, that patient has pre-renal azotemia. Yeah, they have pre-renal azotemia, but it might be due to congestive heart failure. And you say, give 2 liters of normal saline. So loop diuretic should be used in CHF, of course. If the patient has ATN, you've established they have ATN, but they're hypovolemic, you still give the fluid, because they're not going to get better till they get some fluid, but don't overfill them. You know, you ever filled up a lawnmower gas tank? The gas tank is like flat, elongated, and you're putting the gas in, and finally it gets up there and it overflows. Well, that's what's going to happen with a patient with ATN. They don't have an outlet. They're not going to pee. You give them fluid, they're not going to pee. So don't look for them to pee by giving them more fluid, even though they're hypovolemic when you're giving it. So you cautiously give it. You look at things. You look to see if they. Well, I probably order more chest X-rays than anybody, and maybe too many. But the chest X-ray is the best non-invasive means of determining whether your patient is overloaded or not. If they're already replete, then try a diuretic. And I usually start at 40, 80 milligrams, go up to 160 milligrams, and usually stop there. I used to say 240, but it's usually useless to go past 160. If that's not working, add metolazone. If that's not working, I put them on a Lasix drip. And if that's not working, don't give any more Lasix. The next thing you'll have to do is renal replacement therapy. So there's been some new, I decided to put this slide up because hyperkalemia, of course, occurs very frequently in AKI, more frequently than in CKD, as we discussed. So there's new drugs out that help us with hyperkalemia now. But first, and I've seen this many times, get consulted for hyperkalemia and the patient's on spironolactone, or they're actually on a potassium supplement. So make sure they're not taking any drugs or ACE or an ARB. So make sure they're not taking a drug that increases their potassium. Put them on a low potassium diet, simple little things, but very often it doesn't occur. KX latest was our old standby, a lot of problems with it, colon problems. And so they've come out with a couple of new ones, Veltazza and Lokelma. And Lokelma is on the formulary now. And it's probably the drug you ought to use. 10 grams is the usual dose. Big warning comes up, not to be used in acute hyperkalemia. Well, I don't know why. I mean, I guess they think that it's not going to bring it down fast enough, but it is going to help, so it can be used. Alkalization. Most of our patients with AKI are not only hyperkalemic, but they're acidotic. And the number one, outside of renal replacement therapy, the number one mechanism to lower potassium in an acidotic patient is to give them bicarbonate. The potassium will flood into the cell, and you can lower potassium faster that way than any other mechanism. Of course, glucose in a non-diabetic, you use D50 in a non-diabetic, you don't have to give insulin, but everybody does. And that'll put the potassium into the cell too. Calcium does not lower potassium, it only protects the myocardium from the hyperkalemia. But it should be used in patients with severe hyperkalemia. Beta-2 agonists, albuterol, and I think that the use of a loop diuretic in a patient with hyperkalemia that is not volume overloaded is not a good practice. Generally, patients with AKI are also hypertensive. They usually do not need antihypertensive medication unless they were hypertensive before they developed AKI. They were already on antihypertensive medication. Of course, they're going to need to continue it. But they're usually just volume overloaded, and sodium and fluid restriction and loop diuretic usually is enough to take care of them. So even though the majority of patients with AKI have AKI because of hypoperfusion, the majority of patients with AKI are fluid overloaded. So decreased urine output is not a reason to give saline all by itself. You have to know that what you're dealing with. You could be dealing with a patient with congestive heart failure. You could be dealing with a patient that has AKI that's already volume replete, and that's what you're usually dealing with. Now, that isn't to say that a septic patient shouldn't receive saline when they hit the emergency room. But generally, septic shock with AKI, they don't need much more than 3 liters of saline. And I think we've done a lot better job on that over the last 5 or 6 years. I used to see 6 to 12 liters of saline within 24 hours. And it's like, well, the blood pressure's still down and they're still not peeing, so we have to just keep giving the saline. And of course, what you end up with is fulminant pulmonary edema in patients on the ventilator when they weren't before. The insensible loss of water per day is about 850 cc's, but we make water from oxidation of our foods to the tune of about 400 cc's. So the net insensible loss is somewhere around 400 to 500 cc's a day. You need to take that into consideration when you're giving volume back to your patients. So you got 500, a minus 500 to deal with when you start figuring out how much volume to give. And if they're on a ventilator, it's half of that because they're getting a lot of fluid back from the ventilator. They're not losing insensible water through their lungs. Of course, low sodium, low potassium, high calorie diet, about 35 calories per kilogram, and low protein diet. And we just say low protein in AKI because we know it helps patients with CKD, but there's been no big study done that a low protein diet helps in AKI. So those things that affect the prognosis, of course, we all understand. How bad is the underlying disease? Is infection part of it? They have an hemorrhage, surgery. Patients with oliguria or anuria do not do as well as patients who are non-oliguric. And of course, older patients don't do as well either. So this was a study done years ago, and it still holds true today. By the way, this is the bottom of this chart. Mortality for a hospitalized AKI patient is 40 to 50%. And if they're in the intensive care unit, it's somewhere around 60%. And if they're septic in the intensive care unit, it's somewhere around 75%. So I like to think we do better than that, but we've never done a study. Maybe that's something you can do, Schwartz. So, cause of death in an AKI patient, look at hyperkalemia. So everybody with AKI usually has hyperkalemia, but the cause of death is only 2%. It ought to be 0. We have renal replacement therapy. Septicemia, 40%, GI hemorrhage, 25%, and the rest are minimal. So, when do you acutely dialyze outside of toxins? Hyperkalemia, how bad does the potassium have to be? Well, you've got to judge that based upon, is the patient already making urine? Have they responded to diuretics? Were they on a drug that would cause their potassium to be high in the first place, and you just got to remove it? How fast is the potassium rising? So I just can't give you a number. When do you dialyze for hyperkalemia? But generally, anybody with a potassium over 6.5, you need to seriously consider it. Profound metabolic acidosis, once again, can't tell you, how bad that acidosis should be, depending on how the patient is doing. Are they making urine? Are they looking better? Is the bicarbonate coming up on its own? But generally, when that bicarbonate is below 15, we're thinking seriously about renal replacement therapy. Probably the number one reason that I have to dialyze a patient is pulmonary edema. And I would say that the majority of the time, that is because the patient came in oliguric, volume replete, and received over 48 hours before I was consulted 4 or 5 liters of saline. That doesn't mean they weren't going to be dialyzed anyway. But when I see the case for the first time, they very often have pulmonary edema. Now this is a tough one. Uremic signs and symptoms, encephalopathy, where you can have encephalopathy, anorexia for a lot of reasons. Pericardial friction rub, that's pretty late in uremia. But if you have a patient with a pericardial friction rub that has an elevated BUN and creatinine, they probably should be dialyzed. Myoclonic jerking or seizures, of course, that would be an indication. And then the last reason, prophylactically, that's why I usually dialyze people, because we watch the BUN and creatinine go up. It's going up over the last 3 or 4 days. It doesn't look like it's going to turn around. Well, why wait till they get sick? Why wait till their potassium's 7.2 or they develop severe pulmonary edema? You just dialyze them ahead of time. And this is the usual reason we do acute dialysis. Okay. So I just want to summarize that AKI is 75% of the time due to ATN. ATN patients usually recover from if they recover. So if the AKI doesn't kill them or whatever the underlying cause is that doesn't kill them, they're going to get better. Acute cortical necrosis is very rare. You may not see it in a lifetime. I think I've seen 2 cases in 43 years. Generally, we don't ever get to that point. The patient with AKI generally is already fluid overloaded, so be careful that gut decision to make to give IV fluids because the patient's oliguric. And if they're also hypotensive because they're septic or because they're in congestive heart failure, that would be a bad thing to give fluids. On the other hand, you examine your patient, you find that they're volume depleted, you've got to give them volume or their kidneys aren't going to get better. Septic patient, they've got to receive fluid. That's part of the treatment of sepsis. It's malpractice not to give saline in a septic individual. In the intensive care unit, the number one reason that our patients have AKI is sepsis, septic shock. Distinguish between AKI and CKD based upon history. That's going to be the number one thing. But if you don't have the history, then you've got to look at things like the urinalysis and distinguishing between pre-renal azotemia and AKI. You have a lot of labs that you can do that we talked about, fractional excretion of sodium, just the urinary sodium, urine osmolality, and look at the patient. Physical examination. Okay, those are the big things. Any questions? Yes, sir.
We're talking about like sepsis, just trying to see what your opinion is, lactated ringer versus normal saline and large volume resuscitation in terms of acidosis.
Yeah. I think that probably there isn't going to be a whole big difference. If I think that I need to give to help the patient with their metabolic acidosis, I'm going to give them bicarbonate. So, you know, the residents realize this on the order sheets. You can put in IV fluid, I think, and then up comes up a whole list of IVs that you can give. So if you have a patient that's not diabetic and they're severely acidotic, well, I'll give them 150 milliequivalents in D5W, a liter of D5W. If they are diabetic, you can use sterile water because it's not hypoosmolar because you're using 150 milliequivalents of sodium bicarbonate. So I don't use lactated ringers. The other problem with lactated ringers is if you don't have a liver, if you have a patient with a bad liver, that lactate stays lactate. It doesn't turn into bicarbonate. And so you make the acidosis even worse. So I just, a lot of times we'll use half normal saline with 75 milliequivalents of bicarbonate. So if we want to fix the acidosis, we use bicarbonate.
You said nephrotoxic ATN is frequently non-oliguric.
Yes.
What about with NSAIDs, since they're going to be constricting the afferent arteriole? Will that cause oliguria?
They usually are not oliguric, even with NSAIDs. And vancomycin toxicity is usually not oliguric. Vancomycin toxicity, by the way, it lasts forever. Usually, like with NSAIDs, you stop the NSAID and they start getting better. Get the contrast, it gets bad, and then they get better. But with vancomycin, once you get to that, and I've seen levels at 50, the patient may take 7 to 14 days to recover from it, which costs the hospital a lot of money too. All right.
If you want an intrinsic kidney disease, if you kind of rolled out pre-renal and post-renal and you've got intrinsic, how aggressively do you want our people to work that up for the less common causes, the membranous causes, the hepatitis, the autoimmune causes? Do you want that done before they reach out to you?
Well, I don't, so the big tip off is RBCs in the urine, and especially if they say there's an RBC cast. But if there's no RBCs in the urine or minimal RBCs in the urine, or if there's an obvious reason why there's RBCs in the urine, like they have a stone or cystitis, I don't think they should work it up. But I call that the $1 million workup because it's very expensive. But I don't mind them working up if there's RBCs in the urine and there's not an obvious reason why there's RBCs and not an obvious reason why they have AKI.
I guess my question was more, do you want that done prior to nephrology getting consulted, or is it better to be done in combination with you if we see significant proteinuria or significant RBCs?
Yeah, it's okay. If they have RBCs in the urine, to look at that first. Nikita does it all the time. Anything else? All right, well, you're experts.
Have a good day.